Every cancer patient asks the same question. What happens next? Surprisingly, the answer often isn't found in the operating room. It comes from the pathology laboratory. The microscope doesn't simply confirm that a tumor is cancer. It reveals how dangerous that cancer is, whether surgery was successful, how likely it is to return, and which treatment offers the patient the greatest chance of survival. This is why pathologists are often called the doctors behind the diagnosis. Once a surgeon removes a tumor, the pathologist's work is only beginning. The tissue is carefully processed, stained, and examined under the microscope to answer several critical questions that will directly influence the patient's care. The first question is, was the entire tumor successfully removed? To answer this, the pathologist examines the edges of the surgical specimen, known as the surgical margins. If no cancer cells are present at the margins, called negative or clear margins, it suggests that the surgeon removed the entire tumor. However, if cancer cells extend all the way to the edge of the specimen, producing positive margins, microscopic cancer may still remain inside the patient. In such cases, additional surgery, radiation therapy, or other treatments may be recommended to reduce the risk of recurrence. The next question is equally important. How aggressive is this cancer? Not all cancers behave the same way. Under the microscope, some tumors still resemble the normal tissue from which they originated. Their cells remain relatively organized, divide slowly, and generally spread less aggressively. These are called low-grade tumors. Other tumors look dramatically different from normal tissue. Their cells appear highly abnormal, with enlarged irregular nuclei, loss of normal organization, and numerous cells actively dividing. These are high-grade tumors, which usually grow faster, invade surrounding tissues more readily, and often require more aggressive treatment. At this point, it's important to distinguish between two terms that are often confused: tumor grade and cancer stage. Tumor grade describes what the cancer looks like under the microscope. It reflects the biology of the tumor, how abnormal the cells appear, and how aggressively they are likely to behave. Cancer stage, in contrast, describes how far the cancer has spread throughout the body. It reflects the extent of the disease rather than its appearance. These are not the same thing. A patient may have a high-grade tumor that is still confined to its original location, while another patient may have a relatively low-grade tumor that has already spread to nearby lymph nodes or distant organs. Both pieces of information are essential because they answer different clinical questions. Treatment decisions usually depend on both the tumor grade and the cancer stage, but each influences treatment in a different way. The cancer stage tells doctors how much cancer is present and where it has spread. This determines how extensive the treatment needs to be. That is, how many treatment approaches may be required or how much of the body needs to be treated. For example, an early-stage cancer that remains confined to one location may be cured with surgery alone. However, if the cancer has spread to nearby lymph nodes or distant organs, the treatment often becomes more extensive, combining surgery with chemotherapy, radiation therapy, targeted therapy, immunotherapy, or several of these treatments together. The tumor grade, on the other hand, tells doctors how aggressive the cancer cells appear under the microscope. This determines how intensive the treatment should be. That is, how strong or aggressive the treatment itself needs to be. Even if two patients have cancers at exactly the same stage, the patient with a high-grade tumor may require stronger chemotherapy, more treatment cycles, closer monitoring, or additional therapies because high-grade tumors tend to grow and spread more rapidly. A patient with a low-grade tumor at the same stage may achieve excellent results with less intensive treatment. A simple way to remember the difference is this. Stage answers the question, how much treatment is needed? Grade answers the question, how aggressive should that treatment be? Together, along with molecular biomarkers such as HER2 or EGFR mutations, and the patient's overall health. These factors allow physicians to design a truly personalized treatment plan. To determine the grade, pathologists carefully evaluate several microscopic features. They examine how closely the tumor resembles normal tissue, a characteristic called differentiation. They assess nuclear pleomorphism, meaning how much the nuclei vary in size and shape. They count mitotic figures to determine how rapidly the cells are dividing, evaluate the overall architecture of the tissue, and look for areas of necrosis, where rapidly growing cancer has outgrown its blood supply. Together, these microscopic observations provide a remarkably accurate picture of how aggressive the cancer is likely to be. Histopathology can also predict whether certain precancerous conditions are likely to become cancer. A classic example is endometrial hyperplasia, an abnormal thickening of the uterine lining. Simple hyperplasia, without significant cellular abnormalities, carries less than a 1% chance of progressing to endometrial cancer and is often managed conservatively. In contrast, atypical hyperplasia contains abnormal cells that already resemble early cancer and carries a much higher risk of progressing to invasive cancer if left untreated. Recognizing this difference under the microscope allows physicians to intervene before cancer actually develops. Histopathology also plays a central role in determining the cancer stage by evaluating whether the disease has spread. Consider colorectal cancer. During surgery, nearby lymph nodes are removed together with the tumor. Each lymph node is then examined under the microscope. If no cancer cells are found, the disease remains at an earlier stage, often requiring less extensive treatment and carrying a better prognosis. However, if cancer cells are discovered within the lymph nodes, this indicates that the tumor has begun to spread. The cancer is assigned a higher stage, the risk of recurrence increases, and chemotherapy is often recommended after surgery to destroy microscopic cancer cells that may already exist elsewhere in the body. Even after treatment begins, pathology continues to guide patient care. Follow-up biopsies can reveal whether chemotherapy, radiation therapy, targeted therapy, or immunotherapy is effectively destroying cancer cells. Rather than relying solely on imaging studies, physicians can directly observe how the tumor is responding at the cellular level and adjust treatment accordingly. Ultimately, every microscopic observation contributes to a much larger clinical picture. Histopathology establishes the diagnosis, measures tumor grade, determines cancer stage, evaluates whether the tumor has been completely removed, predicts recurrence, estimates survival, identifies important molecular biomarkers, and helps physicians choose both the extent and the intensity of treatment for every individual patient. This is why histopathology remains the gold standard for cancer diagnosis. A tiny piece of tissue placed under a microscope can reveal information that no CT scan, MRI, ultrasound, or mammogram can provide on its own. Imaging can detect that a mass exists, but only pathology can definitively determine what that mass truly is, how dangerous it is, how far it has progressed, and how it should be treated. In the end, pathology transforms a small tissue sample into one of the most powerful tools in modern medicine, turning microscopic observations into life-saving decisions and making truly personalized cancer care possible.